Okay, Dr. Crosswhite here. We're going to finish up chapter 17 with this video lecture, and mostly we're going to focus on finishing up ventilation. In particular, the learning objectives that this video will cover will include, I think we finished up in class talking about the lung volumes, how they change during normal breathing, and how that affects flow in the respiratory system. But we're definitely going to discuss atmospheric and intrapleural pressure. And we're going to keep going with, we're going to discuss how alveolar and intrapleural pressure change during the respiratory cycle. And then we'll get into some factors that affect lung function or impact lung function, including compliance, elastance, and surface tension. And then we'll talk about airway resistance, emphasizing local and reflex controls that regulate bronchodilation and bronchoconstriction. We'll finish up talking about total pulmonary ventilation versus alveolar ventilation, and how gases change during hyper and hypoventilation. And then finally, a little bit on ventilation perfusion matching. And just want to point out that looking at these slides, I don't believe I included information on this very last learning objective here, comparing obstructive and restrictive lung diseases. If we have time in class, the next time we meet, we might discuss some of these, but the video will not. Okay, so picking up from where we left off, in class we were discussing how the change in the thorax, so the chest cavity expanding or decreasing, how that is going to increase or decrease pressure, and that's going to influence airflow. So there are some different pressure gradients that we need to discuss before we get into the nitty-gritty of it. But basically the concept here that this diagram is trying to show you is that in order for oxygen to move from the atmosphere and into our body, we've got to maintain a constant pressure gradient. So if we're discussing the partial pressure of oxygen in the atmosphere, and remember, just partial pressure, so not atmospheric pressure here, it's going to equal around 160 millimeters of mercury. And then the tissue, all the way down here, it's going to be around 40 millimeters of mercury. Okay, so we're starting out with a high pressure here and a lower pressure here, so oxygen is going to naturally want to move down its pressure gradient. Okay, so when we're talking about gradients during ventilation, then we've already discussed a little bit about atmospheric pressure. Typically when we're discussing these pressures, we're talking about the partial pressures of individual gases, like I just covered in the partial pressure of oxygen. We can also talk about partial pressure of carbon dioxide as well. The next type of pressure that you need to be aware of is something that's called the alveolar pressure. Okay, so this is quite literally the pressure of the gases in the alveoli themselves. And again, if we go back to oxygen, the atmosphere is partial pressure of O2 in the atmosphere is around 160, but in the alveoli, it's around 100 millimeters of mercury. Okay. And then the next pressure that we need to discuss is the intrapleural pressure, which is not shown on this diagram, but we'll talk about in the next couple slides. But basically, try to think about that intrapleural space that we've discussed previously in this chapter. There is some fluid in there, so there's a pressure, the pressure in the intrapleural cavity is subatmospheric. We'll come back to it. The last two are partial pressures of the gases either in the blood or the tissues. So alveolar partial pressure of O2 in the alveoli is around 100. It's around the same in the blood. Okay. And then previously I mentioned oxygen in the tissues. The point here is that because of this gradient, oxygen starts out high, it moves into the alveoli because the partial pressure is lower. It diffuses into the blood, and then it travels throughout the bloodstream, and it moves down its concentration gradient into the tissues. Okay? We won't go over the numbers for CO2 right now, but you can imagine that this gradient, even though the numbers would not be the same, the gradient is opposite. The cells are constantly producing CO2, and then, so it's a high concentration here, low CO2 concentration in the atmosphere, so CO2 is going to move out in this direction. All right, so we discussed how the chest cavity or the thorax changes during the respiratory cycle. We've discussed some pressure gradients in the respiratory cycle. The last thing I want to mention to kind of tie all these points together is how when during inspiration and expiration, the pressure in the alveoli and the intrapleural cavity is going to change, and how that relates to the movement of air. So we've got this graph over here, and it's just showing respiratory cycles. So we start here at the end of inspiration, end of expiration, and we've got one respiratory cycle. Okay, that's a round of inspiration and expiration. We're also showing the intrapleural pressure and the volume of air. And one thing I want to point out is that the book, what it's saying here, so on the left side of the screen is pressure, but it's not in the units, it's not in the numbers that we're used to. But basically, what 0 is 760 millimeters of mercury. This is atmospheric, okay? It's just using this as a baseline, so the book is calling it 0. But the point is, as we begin to inspire, our chest expands, okay? Because the volume is increasing in our chest cavity, that pressure in the alveoli is dropping, okay? It's dropping below atmospheric pressure, so we're creating that pressure gradient just by expanding the volume. And the same applies to that intrapleural pressure, which is shown here. So the pressure outside of the lung in the pleural cavity. So as we expand our chest, both alveolar pressure and intrapleural pressure drop, and notice what happens when that occurs. This is the volume of air down here. So as these pressures drop, we create the situation where air can rush into our lungs. Okay? And then at the end of inspiration and expiration begins, we're compressing the chest cavity, it's moving back in, it's recoiling, and notice that the pressure in the alveoli and the intrapleural pressure begin to rise. And once pressure in the alveoli really exceeds atmospheric pressure, it goes above 0, we stop, or air stops moving into our chest cavity. So this is just showing the relationship between the alveolar pressure, intrapleural pressure, and how air moves into our chest cavity, our lungs. Okay, so a little bit more on the intrapleural pressure, and more so a clinical situation here. You may or may not have heard of a pneumothorax, but you probably have heard of a collapsed lung. So this is when there's a compromise in the intrapleural pressure. Typically, this intrapleural pressure is lower or subatmospheric compared to the atmosphere. However, trauma to the chest, usually some type of puncture wound, it has the potential to open or expose that intrapleural cavity to the atmosphere. And as a result, let's say here's the intrapleural pressure, here's the atmosphere, and if there is a break or an exposure, then you create the situation where air will move down a concentration gradient into the chest cavity. And because of that, it's going to cause the collapse of the lung in that cavity. So the point being here is that it's a compromise in the intrapleural pressure, and to correct or treat a pneumothorax, basically what you have to do is somehow remove the air the excess air from that intrapleural cavity, and then you have to repair that that wound, that puncture, etc., that compromise in the chest wall in order to seal off the lungs again, seal off the chest cavity. Just want to highlight that having one collapsed lung usually isn't a fatal situation. Many people survive an event where they have one collapsed lung. Two, that's a completely different situation. So here's just a cartoon showing or illustrating this point. Normally you have intrapleural pressure here. It's lower than the atmosphere, but when there's, like I said, an injury, some type of puncture wound, because the pressure out in the air or the atmosphere is high and it's lower here, air will rush into the chest cavity, and that equalizes the pressure in the atmosphere and the pleural cavity, and because of that, that's going to cause the lung to collapse. Okay, so that's a pneumothorax. Now we're going to switch gears and talk about some factors that actually impact lung function. So these are some basic properties of the lungs that need to be maintained in order for, I'd say, optimal performance, optimal gas exchange. The first one we need to talk about, and these first two are really related, compliance. Okay, so compliance, this is the ability of the lungs to stretch. Okay, so when the lungs have high compliance, that means they can stretch a lot, but if the lungs have compromised compliance, they can't stretch as much. However, you might think, well, great, we want really, really high compliance of the lungs. That's somewhat true. However, too much stretch can actually lead to what's called low elastance. So if the lungs stretch too much, they may not be able to return to their original shape, and that's what elastance is. A really easy way to think about this is if you have a pair of athletic shorts or gym shorts, and let's say they're old when they've gone through some, you've had them a long time, you can imagine that elastic band. That elastic band does not return to its original shape. All right, so kind of introduced you to elastance. This is the recoil, the ability of the lungs to actually return to their, I'd say, their resting state, okay, or the resting volume. An example of this is emphysema, or a disease where lung elastance is compromised. During, or in individuals who have emphysema, this disease destroys the elastin fibers. It's a type of connective tissue, and the elastin fibers are destroyed in the lungs, and as a result, they can stretch. These lungs can stretch very easily, so they have high compliance, but they don't return to their regular volume, and as a result, it's more difficult for these patients to expire air, so they actually have to, expiration becomes more and more active over time. The third factor that's going to influence lung function is this concept here called surface tension. Okay? So the alveoli, think back to those pictures I showed earlier in the chapter, basically tiny little clusters of grapes. You can think of them as little bubbles of tissue, okay? And the alveoli are covered in fluid. We have to create or maintain this moist environment that promotes diffusion of gases, okay? So alveoli are these little tissue bubbles, they're covered in fluid, and in reality, not all alveoli are the same size. There are slightly larger ones, there are slightly smaller ones. But point here, that fluid that covers them creates surface tension. You can think about this like a pool or a lake or river. At the top of the water, you have surface tension. And what surface tension is when water is stretched across a surface. Because of the hydrogen bonding, you create surface tension. And the the fact here, or the point here, is that surface tension, it actually increases the pressure of the alveoli, which would oppose or make it harder for gas to diffuse. Okay, so typically, if you have too much surface tension on the alveoli, this would slow down the rate of gas exchange. This is bad. So as a result, our lungs and those type 2 alveolar cells that are present in the alveoli, they release a chemical called surfactant, and this chemical actually decreases surface tension. And there's a law that was proposed by an individual. His last name is Laplace. So the law of Laplace explains this relationship. And here's the actual formula, but I'm less concerned about the formula, and let's just talk about this figure right here. I think it explains it more so than the formula. So as I mentioned, alveoli are these little tissue bubbles, and they are not all the same size. And what this means is that if we have two bubbles, they're different sizes, according to Laplace, the pressure is going to be greater in the smaller bubble. Okay? So they're different, they have different surface areas, but because of the surface tension will be higher on a smaller bubble. So what happens is the alveoli produce surface tension, they produce surfactant, which is shown by these little blue bubbles, and the surfactants actually decrease the surface tension, and they allow for the equalization of pressure between the alveoli, so you don't have low pressure here and high pressure here. Basically, it makes the pressures equal. Okay, so we'll probably need to cover this again in class, but take a few minutes to go through law of Laplace and work through this concept of surface tension. All right, so those are three factors that impact lung function. The fourth one that we've got to discuss is our good friend resistance. Okay? Just like we talked about resistance in the cardiovascular system, resistance does apply to the airways as well, our lungs. So similar concept. I'm not showing the formula for resistance, but if you can think back to what we discussed in cardiovascular system, same formula. And just as we discussed in blood vessels, when we discuss ventilation, length is constant in the human body, so the length of our airways is constant. They're not changing, they're not growing, they're not increasing or decreasing. So the result is that diameter is the largest factor that impacts resistance. And basically, the larger the airway, it's going to offer less resistance. The smaller the airway has the potential to provide more resistance. Now, in the lungs, the bronchioles are the site where they provide, I shouldn't say, this is technically incorrect, and you can ask that question in class why it's incorrect, but the bronchioles are the site of what I should say the most active site of resistance in the lungs. Okay? So just as in the arterioles, the bronchioles are surrounded by smooth muscle, and because of that, these smooth muscles will respond to neural and hormonal and paracontrol and either constrict or relax. And as they do that, it's going to dilate or constrict the bronchioles themselves. Okay, so just a reminder, looking back at the bronchioles, the respiratory bronchioles, and the alveoli. So we're really talking about smooth muscle that surrounds the bronchioles located here. And just as in the cardiovascular system, there's similar concepts apply. So if we're talking the neural control, and in particular, our good friend, the autonomics, parasympathetic control is the major factor here. So parasympathetic innervation causes bronchoconstriction. So again, this is kind of a on-off situation. The more parasympathetic activity is going to trigger more bronchoconstriction, but the less parasympathetic activity is going to allow the bronchioles to relax and dilate. There is no sympathetic input on the bronchioles. Think about that. Again, that'd be another good discussion to have when we come back in class of why the bronchioles are not under sympathetic innervation. Our good friend epinephrine, catecholamine, released by the adrenal gland, circulates in the blood. The blood reaches the smooth muscles surrounding the bronchioles and again binds beta-2 receptors on those smooth muscle cells, and this causes the smooth muscles to relax and therefore bronchodilate. Think about exercise. If you're exercising, you're releasing massive amounts or a large amount of epinephrine. It's circulating in your bloodstream, and when you're exercising, you need more air, and so the last thing you want is to cause constriction. So epinephrine released during exercise, fight or flight, causes dilation of the bronchioles so you can take in more air. The last one, and I have right here majority, so this is the majority of control or the majority of regulation of the bronchioles, and what I mean by that is like minute to minute, second to second regulation, mostly done by paracrine control. And a couple paracrines or chemicals that I want to discuss: high carbon dioxide and histamine. So this makes sense. If there's an increased amount of carbon dioxide in the bronchioles, in the alveoli, this is going to trigger bronchodilation. So basically your lungs are detecting, oh, we have too much CO2, we need to dilate and get rid of the CO2, bring in more oxygen, we need to normalize. The other one, and it causes an opposite response, is bronchoconstriction. Okay, and this is histamine. So histamine is a chemical released by many different types of cells, immune cells, damaged cells. It's most commonly associated with allergic reactions, and especially in asthmatics. They have an asthma attack. You can have an increased histamine release, and this leads to bronchoconstriction. So too much histamine can cause severe bronchoconstriction, and that can be potentially very dangerous. And I have right here, most of us are associated with, or have heard of EpiPens being given in allergic reaction situations. I have it listed under histamine, but think about what we've just discovered, or not discovered, what we've just talked about, and especially epinephrine, hint right there, of why EpiPens are given to patients suffering a severe allergic reaction, in the case, let's just say, a large amount of histamine. And we can discuss that in class. All right, here's a diagram just showing you, I thought this illustrated the idea, the concept of bronchoconstriction pretty well. This is not from your book, but it's just showing under normal situations you have a bronchial airway is not restricted. For whatever reason you have too much, you have an increase in constriction, and it reduces airflow. And in this situation, this person is taking medication. You know, this is common for asthmatics, people with allergies. This medication can dilates the constricted bronchiole and promotes airflow. Okay, so here are factors. It's a table summary of factors that affect airway resistance. So go through that, nothing too difficult, and basically summarizes what we've discussed so far. Okay, so those are several factors that impact lung function. We're going to shift gears and now discuss the concept of total pulmonary ventilation versus alveolar ventilation. So this is just the total amount of air that is moving into the lungs. And when we discuss, when we have to talk about pulmonary ventilation or total pulmonary ventilation, rate and depth, so the rate of breathing and the depth of breathing is going to determine the efficiency of gas exchange. So we can calculate total pulmonary ventilation very easily if we just know a couple variables. And the first one is our ventilation rate. So how many times per minute are you breathing? How many breaths per minute? How many respiratory cycles are occurring per minute? And in each of those respiratory cycles, what's your tidal volume? So basically this is quiet breathing. Okay. So let's just discuss some numbers for what we call normal rates. Okay. So typically your ventilation rate, how many times you breathe per minute, this can be variable. Children, adults, men, women, various situations, but typically that ventilation rate falls between 12 and 20 breaths per minute. Okay, so for the purpose of this, we're just going to go on the lower end and we're going to use 12 breaths per minute. So that's about 1 cycle per 5 seconds. And then we discussed in class how average tidal volume is around half a liter or 500 mils of air. So all we have to do to calculate total pulmonary ventilation during quiet breathing is 12 breaths per minute times 500 mils per breath, and that comes out to about 6,000 mils per minute, or 6 liters of air per minute is occurring is our total pulmonary ventilation rate. However, okay, so that's the total amount of air that we're moving in 1 minute. However, not all of that air reaches the alveoli, and that is because of this concept right here, the anatomical dead space. Okay, so it's around 150 of the 500 mils for every breath, and what this means is that some of that air, because it stays in the conducting airways, I shouldn't say upper airways, but our trachs and our large airways, because they don't reach the alveoli, there's no gas exchange. That is why it's anatomical dead space. Okay? So figure 17.2 or 0.12 tries to illustrate this. I think it does it pretty poorly. We can talk about it in class. We can try to break it down and make it a little more simple. But basically, of that tidal volume, the 500 mils, due to anatomical dead space, only about 350 mils actually gets exchanged. Okay, so this is the figure that I was talking about. However, I think the top part A, pretty easy and straightforward. It's giving you the calculations for total pulmonary ventilation, and then this other ventilation, what we call alveolar ventilation. So this is literally how much air reaches alveoli in, sorry, it's kind of getting a little difficult to read. So how much air reaches the alveoli in 1 minute. That's what alveolar ventilation is. So to calculate that, assuming that the dead space, anatomical dead space, is 150, like I just mentioned, similar calculation, 12 breaths per minute, but you multiply that by the tidal volume minus your anatomical dead space, 500 minus 150, and because of that, your alveolar ventilation is much less than the total pulmonary ventilation. So that's what this slide is showing you here how to calculate alveolar ventilation, literally how much air are we exchanging in 1 minute. And we just went over this calculation, but notice this number is much lower than your total pulmonary ventilation. So less air is reaching the alveoli. Down here, this figure question, I took this from your book. I think this is a good way to get some practice in. And you can see how what this does is it tries to illustrate the point of when your tidal volume changes or when your ventilation rate changes, how does that affect both the total pulmonary ventilation rate and the alveolar ventilation rate? So use the two simple formulas that we just covered to fill out this table, and I think it's a really good practice for you. Going back to the rate and depth and how that impacts your ventilation, if you many of us have experienced hypo or hyperventilation situations, but if you think about it just physiologically, functionally, very short, rapid breathing that actually decreases the volume of air that's reaching the alveoli. So longer, deeper breathing, it increases the amount of air that reaches the alveoli. So our ventilation rate in particular is going to really impact our ventilation and how much air is reaching the alveoli, and therefore how much gas is being exchanged. There's many different types of, so depending on our rates and these types and patterns, we have different, I guess, clinical situations or terms for the patterns of ventilation. Okay, so let's see. Let's start with a couple that most of you have probably heard. So hyperventilation and hypoventilation. So this is when the rate of breathing has increased. This is when the rate of breathing has decreased. So increased respiratory rate, and this is going to, we'll cover it here in a second. So this is hyperventilation is just an increased respiratory rate and or volume without an increase in metabolism. We'll cover that more in the next chapter as well. Hypoventilation is just a decreased alveolar ventilation. You're not getting enough oxygen or gas exchange, I should say. So this is really due to, these two really focus on respiratory rate or alveolar ventilation rate, whereas hyperpnea, tachypnea, dyspnea, those are all referring to the rates. Okay, so hyperpnea, increased respiratory rate. Okay. Tachypnea, this is rapid breathing as well, but it's associated with decreased depth. Okay. Dyspnea is difficulty breathing, sometimes described as air hunger. And then we have another couple terms. Apnea, most of us have heard of sleep apnea. So while you sleep, individuals sometimes actually stop breathing. And this can be for quite a long time, several seconds, 10 seconds, it just depends. Apnea can, trying to think, the severity of sleep apnea can really change or be varied. And then our normal quiet breathing is just called eupnea. Okay? So we can talk a little bit more about these in class and the differences between them, but lots of different ways to describe ventilation, breathing, and patterns. Kind of getting into how the rate and breathing actually impact our gas exchange. This is illustrated by this graph right here. So on the bottom, we have the alveolar ventilation. So this is how much air is reaching the alveoli per minute. And then on the y-axis, we have the partial pressures of certain gases. And this is, so the graph shows both partial pressure of oxygen, partial pressure of carbon dioxide. So if we start here in the middle with a normal ventilation rate, 12 breaths per minute, tidal volume around 500 mils, partial pressure of oxygen in the alveoli should be around 100 millimeters of mercury, and the partial pressure of CO2 should be around 40 millimeters of mercury. But notice how these partial pressures of O2 and CO2 are connected in terms of when we increase our breathing rate or when we decrease our breathing rate. Okay. So as we start to hyperventilate, increase in rate, but not an increase in depth, we're increasing the partial pressure of oxygen, decreasing partial pressure of CO2. Okay? So what happens is we increase oxygen, decrease CO2, and you might think, well, what's the big deal there? The problem is low CO2 can be very detrimental. So what happens is our blood pH actually increases, and this can cause one to be dizzy, weak, maybe even faint, and in severe cases it can trigger seizures. So this is really impacting our blood pH in this situation. And then obviously hypoventilation, when our breathing rate decreases, partial pressure of oxygen drops, partial pressure of CO2 increases, and this one you're probably more familiar with. Low O2 problems, should I have to explain the dangers there in that situation? Hopefully not. All right, last couple things that we need to talk about. I've mentioned this a couple times in this lecture, but also in class, and this is the concept of what is called ventilation perfusion matching. So ventilation perfusion is the concept that the body tries or needs to match the amount of air that reaches the alveoli it's matching the amount of air to the blood flow in the alveoli. Okay, so the point here promotes efficient or maximizes CO2 exchange. Or sorry, not CO2 exchange, gas exchange. Okay, so that's what this figure is showing on the right. So we have two alveoli, and we have normal breathing, we have normal airflow, normal blood flow as well. So we have blood that's reaching this alveoli, blood that's reaching this alveoli. They both have O2 that's coming in. They both have CO2 that's leaving. Sorry, lots of red, kind of getting confusing there. But the point is, these alveoli are well ventilated, promote normal airflow. Okay. We'll come back to this concept, but the way the body does this is pulmonary capillaries are a little unique compared to our systemic capillaries. And that is because they're collapsible and they're recruitable. Okay. And I kind of hinted at this in class earlier this week, is how when we exercise or when we need to increase our gas exchange, we can recruit more capillaries in the upper portions of our lungs. Again, just for sake of keeping this video shorter, we can cover that in class the next time we meet. But the point here, during normal situations, alveoli well ventilated, and they're also receiving adequate blood flow. So we're promoting efficient gas exchange. So now, what happens if, let's say, in alveoli, the ventilation is reduced, or the airflow to an alveoli is decreased? So that's what this figure is trying to show you. Up here, notice up here, we have a much smaller bronchiole right here that leads into this alveoli compared to this one right here. So because of that, there's not as much air, there's less air that's reaching this alveoli, and as a result, you have an increase in carbon dioxide, a decrease in oxygen. So how ventilation perfusion matching occurs is that the blood vessel, or the capillary, that is associated with this alveoli, it's going to actually collapse, okay? Because it doesn't make sense for an alveoli that's reduced airflow. We're going to have less gases that are present there, less gas exchange. So we want to, it doesn't make sense to direct blood flow to that alveoli. So as a result, through local mechanisms, paracrines, it causes this capillary to collapse. Okay? And then that blood is redistributed elsewhere to other alveoli that are well ventilated, and therefore we're promoting proper gas exchange in other areas that are receiving proper blood flow. Okay? So let's look at the text over here. So basically, when an alveoli receives less air, its capillary is going to collapse, and this is due to low O2 and high CO2. So it's a combination of both. It's a local mechanism, a paracrine response. However, it is reversible if the alveolar ventilation resumes. So for whatever reason, that alveoli then receives air, that capillary will respond, and it'll open up a bit, blood flow will resume. Okay? So the big picture here, ventilation perfusion matching, is we don't want to waste blood flow to an alveoli that is receiving very little air. Okay? It's just a waste of resources. And the whole point is, not the whole point, another point is that there is some of this going on at rest, and so when we, let's say in a state or a condition where we need to increase gas exchange, we can do it through this mechanism. We can reverse the collapse of some of these capillaries, and we can promote or increase gas exchange. All right, so talked about bronchial constriction, dilation, those methods, those factors that regulate bronchial diameter, talked about ventilation perfusion matching, and I want to challenge you to work through this table on your own and before the next time we meet in class, because it's a little counterintuitive, I'd say, because it's basically the response in the bronchioles is going to be opposite of what you expect, and that's because most of the time we've mostly covered situations in the systemic arteries. So basically what this table is trying to get at is what happens when the gas composition changes in the bronchioles, in the pulmonary arteries, and the systemic arteries, and notice how it's different. Okay, so go through this. I'm not going to go through it on the video, but I'm happy to review this in class. All right, so that's chapter 17. That finishes us up on ventilation. This video went over quite a few learning objectives, so be sure to go through the slides, go through the textbook, go through this video, and then we'll have a pretty good review session the next time we meet. All right, see you guys in class.